Doctor, we can start now.
Can you guys see the screen?
Yes, doctor.
Yeah, today main topic we're talking about ECG interpretation and of course arrhythmia. So you guys understand what the term means by arrhythmia? No? Have you guys heard of this term?
Yes, doctor.
Yeah, as the name suggests, the arrhythmia means AR means abnormal, rhythm means the pattern of the ECG. Arrhythmia means whatever is abnormal with the rhythm. So today we're going to go through a basic understanding and interpretation of ECG. It's more like a revision because I have been talking about this over and over for the past few lectures. And after this lecture, hopefully you guys can be familiar with a few normal or abnormal rhythm that you will see in the ward. Okay. So before we begin, anyone can tell me what rhythm is this? Anyone seen this before? No. Hopefully, in the rest of your life, never see this rhythm now. So this is and after this lecture, hopefully someone can answer me what rhythm is this. Okay. So let's begin by talking about the conduction system. So what makes our heart contract? Because our heart main function is to contract and pump the blood, right? So what drives the contraction? So we need to have a systemic conduction system, like a pacemaker or the generator of the electrical signal that drive the contraction of the heart. So normally, what the normal sequence is that your atrium, both the left and right atrium, will receive signal, and that will start to contract. Left and right atrium will contract together. They will pump the blood into the right into the ventricle through the mitral valve and also the tricuspid valve. When the blood pump into the ventricle, this will stretch the muscle and it will followed by contraction of the ventricle, and they will pump the blood out through the aorta and also through the pulmonary artery to the rest of the heart, the rest of the body. But what drives the signals? So this picture clearly illustrated it. So it all started with the sinoatrial node, which is located just at the wall of the left atrium. It's like the main generator of the signals. So these signals will fire its own signals. It just the terms we use is called depolarization. You send up signals, and this signal will travel in a specific pathway. Let's see. Sorry. How do I change it? No. Okay, never mind. Okay, so the signal will travel from the SA node through the internodal pathway, and you will relay itself in the middle of the septum, which is called the AV node. So when they reach the AV node, you wait and pause for a while for the atrium to contract. After that, you relay signals through the bundle branches and then deliver the rest of the signal to Purkinje fiber. So all this electric signal will deliver to the rest of the heart symmetrically to the left and right ventricle so that it contract at the same time and pump out the blood at the same time. So ECG, the equipment that we use, the aim is to try to identify the signals and try to figure out anything's wrong with the conduction system or not. So the main electrophysiology that we rely on, this is the fundamental basis of it. So the electrical signal generation is happen due to the depolarization, which is caused by the shift of electrolytes in the cells. Usually it's driven by sodium, and repolarization is driven by potassium. Okay, this physiology is important, but you just need to know that it was driven by this action. You do not need to know in details how does it happen. Okay, so okay, so the basic ECG, we always call our ECG is 12 lead ECG, but if you count how many leads is there when we do the ECG? So in the ECG leads, if you've seen someone do the ECG before, you have 4 leads attached to the hand, the left arm, the right arm, the left lower limb, and also the right lower limb. And then there's another 6 chest electrodes, 1 to 6. So total you only have actually 10 electrodes. But then we call it 12 lead ECG because there's 3 leads actually we derive from the standard leads, and another 3 actually derived from augmented leads. Okay, the reason is 12 is because the way we arrange it and pick up the signal using bipolar and unipolar method. So just remember, the way you put the ECG leads, there's 6 chest leads and 4 on the limbs. Okay. All right. If you want to know in details how to put the leads, is good as well. If you've seen the ECG machine before, each of the leads actually labeled already properly for you. LA means it's the left arm, RA means the right arm, and LL means left lower limb, and RL means right lower limb. In fact, it's color coded as well. The right side, the right side is always the red color. The mnemonic that we use to remember is ride your green bike. Good to remember, but you don't need to remember also. Okay, it's practically the way, because we don't have time to look at the marking, so a lot of time we just follow the color. Ride your green bike, so means the red is on the right arm, white yellow is on the left arm, green is over the left lower limb, B is black on the right lower limb. Then the V1 to V6, we have to look at the number. Okay, so you want to know in details which intercostal space to place. These are details. Good to know. You need to remember this. So I mentioned before, the way that we arrange it is to look at the heart in a different angle, and the lead is actually placed surrounding the heart in the oval shaped way, because your heart is always on the left side. So have you seen some movie before that someone maybe a bad person stab a good guy is on the left side of the chest, but patient didn't die, and the heart is on the left side? Any idea what happened to that? Anyone?
What, doctor? What?
Yeah, have you seen the movie before? Someone gonna shoot in the chest, but in the end they didn't die because they were born congenitally. Their heart is on the other side. Have you heard of some story like that before?
Yes, there's I think there's a name for it, but then I don't remember.
Yeah, so that thing that condition is true lah. That actually is there is a condition like that. Someone could have we call it what's it called? They can have a heart. The means they have a mirror syndrome or something like that. Means their organs is actually mirrored. Instead of the left side, they're on the right side. It can happen. If let's say the heart is on the right side, there's term what we call dextrocardia. Means the heart is exactly opposite. It's not on the left side, it's on the right. So how do we put the ECG leads in that case? So you just move it opposite. It's the same. the exact mirror the organ. Let's say your heart is here, so your V1 to V6 also mirrored it. Just terbalik the leads to the right side. Okay, so rarely you will see some patient like that, but if you see someone the heart on the right side, the ECG leads also have to shift to the right. Okay, so this is the thing that you need to remember. The previous few slides, you can forget that also, never mind. But this one is important. Okay, so the standard ECG leads for sinus rhythm, you see a few, we call it interval that you need to remember. Okay, PQ, R, ST, and U. All right, so one ECG, when the ECG is starting to print, when you start the machine, it actually run at the rate of 25 millimeter per second. Means 1 second, it run 25 millimeter. How much is 25 millimeter? Is 5 big boxes. Okay, so one of the big boxes that we're talking about is like this. Maybe this one not so clear. Yeah. So one of these big boxes is actually 0.2 seconds. So 1 second, they run 5 big boxes. Okay, so that is the standard setting that we should see on the ECG machine before we interpret it. The writing speed is always 25 millimeter per second, and the voltage is always 1 millivolt. 1 mm equal to 1 millivolt. We have to make sure the setting is correct before we start interpret, because that's the basis of how we interpret the heart rate and the voltage. Okay, so when we interpret the ECG, the first thing we talking about the heart rate, and then followed by rhythm, and we will interrogate each of the segments whether it's normal or not. So let's start with the heart rate. So how do we know? How do we calculate the heart rate based on the ECGs? So the way we do it, knowing that it will print out 25 millimeter per second, which actually can count by dividing it with a fixed number. Okay, so the usual formula that we use is that we divide 300 by number of big boxes that we see on the ECG strips. Okay, so let me give you an example. This one. Okay, anyone can try. How many big boxes is that? Explain again. Maybe it's a bit confusing. Okay, so this one. Okay, so the way we count it is that we take this is R, this is another R, this QRS complex, this is the next QRS complex. So what we use is that we count the number of big boxes between the QRS complexes. So this is 1 boxes, 2 boxes, 3 boxes, 5 boxes, and 6 boxes. So if you use 300 divided by 6, you get, 1, 2, 3, 4, 5. If let's say you use 300 divided by 5 boxes, how much you get?
60.
You get 60. So the heart rate is 60 beats per minute. So for a regular rhythm, it actually doesn't matter which RR in which QR, which RR interval you take, because they're going to be constant. If you look at this one, 1, 2, 3, 4, 5. You will look at this one, 1, 2, 3, 4, 5. So it's actually a regular heart rate. So you can use any of the RR interval. Okay, so let's try this one. No. Okay, let's try this one. So anyone can. So how many big boxes in between the RR interval?
Three and a half.
Okay, so let's say 1, 2, 3, 3.5. Yeah. So sometimes we just round it off for you to easier to count. If let's say you have calculator, you can just 300 divided by 3.5. But usually we just round it off around 4. So let's say you count around, it's roughly around there, like if you plus minus 1, 2, 3, half is another 1 small boxes. So if you do 300 divided by 4, how much you get?
75.
Yeah, so the 100 is 75. It's as simple as that. Of course, if you have a calculator with you, you want to be more accurate, you can do that. Or you can also use you can also count the small boxes, which will be more troublesome. If you count the small boxes, you have to use 1005 divided by the number of small boxes. So that is quite time consuming. That's why most of the time we just use the number of big boxes. Okay, that's for the rate. Okay, so before I go to the reader, that's fine now. Okay. Yes. All right, a bit of interference. Okay. All right. So before I go to the rhythm will be more complicated. So let's talk about the segment first. Okay. Um, I know this might be a bit overwhelmed, but I want to tell you how do we go about how to interrogate the ECG so that you understand more whenever you see one ECG strips. Okay, so this is a normal sinus rhythm pattern. You see a P, you see a QRS pattern, you see a T, you may or may not see a U. So if you see a P followed by QRS and T, that is a sinus rhythm. All right. So what represent by P wave? Did I have it or not? Not here, not here. Okay, this is bigger. All right. So the P wave is actually to remember it to make it simpler. The P contraction is almost like your atrial contraction, where QRS pattern is your ventricular contraction. All right. That's why you always have an atrial contraction first, followed by a ventricular contraction. You always start with P followed by QRST. So this is the electrical signal that we pick up from one cardiac cycle or cardiac signal. You always start with P, QRS, and T, and each of the segment has its own normal value. So what we do when interpreting is we count the segment or interval of each ECG, see whether it's prolonged or is it shortened or not, or any ST elevation or not, any T inversion or not. That's how we interpret the ECG. Okay, so where is the P wave? This is P wave. P wave is always upright. Most of the time it's upright because it's in for normal ECG, the P is always upright. All right, and PR segments from here to here. This is a PR interval. So the interval that I need you to remember, or segment I need you to know, one is the P wave. Number two is the QRS. You can forget about PR segment, it's fine. So this is QRS. This is ST segment. This is the most important segment you need to remember. And T wave. So you look at the pattern itself, it's like a bump, a spike, and another bump. Okay. So the P and the T bump is always about the same. So if you see something abnormal compared to this picture, something is not right, and your job is to find out why is it abnormal, which we will see in the subsequent sample. Okay. So if you look at the P wave, is about one in small boxes, isn't it? And then your QRS is always narrow. Okay, QRS interval is always about 3 small boxes. You wouldn't more than that. If it's more than 3 small boxes, that means it's a what? That means it's a QRS and interval is prolonged. Okay, that can tell you there's some conduction problem. And ST segment, if you look at this line, is always similar as your isoelectric line. Whenever you see something going up, like ST segment going above your PR segment and the segment between T and U, when something elevated, it's called ST elevation. When it's depressed, it's called ST depression. Okay. Okay. So how about this one? Anyone can tell me what is the heart rate for this ECG on the first picture? How many big boxes is that? How many?
9.
Yeah. So what is the heart rate?
33.33.
Yeah. So you roughly get around 33. So how about this one? This is simpler, right? How many big boxes is that?
3.
How do you
2
count
lah.
3? 2
2
lah,
lah.
2
2,
lah.
2,
This
2.
is 1, this is 2. So 300 divided by 2 is how much?
150.
150, right? Okay. Yeah. So the when you start interpreting, the first thing you want to comment is the rate. So what is normal and what is abnormal? So the normal heart rate we take is between 60 to 100. So anything less than 60 is bradycardia. Anything more than 100 is tachycardia. Okay. So do you see a P wave here? You see a QRS, and this is T. So what type of rhythm is this that you're seeing here? So I
Which one,
mentioned before,
doctor?
when you see P, QRS, and T, this is a sinus this is a sinus beat. So this is a sinus rhythm. So with the heart rate of 33, this is sinus bradycardia. Okay. So what about this one? You do see a P wave, QRS, and this is T. Okay. You see a P, QRS, and T, and U. So this is sinus rhythm. The heart rate is more than 100, is tachycardia. So this is sinus tachycardia. Okay, everyone get this?
Yes.
Yeah. Okay, so okay, not this one. All right, so let's go to. Okay, I think we come back to this one. So nothing to comment is the axis. Um, the axis will not help much for you to interpret the ECG. So for detailed interrogation, we can interpret this, but I don't think this is important for you lah. Huh? So you can forget about this one. More important is I want you to know about the rhythm. Okay. Okay. So this is the normal 12 lead ECG that you will see when you have one in the ward. So can someone try and see what do they see on this ECG? Okay, so for the first thing that when you see an ECG, I know it's too many numbers that make you panic. But the first thing is always comment on the heart rate first. So what is the heart rate and what rhythm is this? So if you look at the number of big boxes, it's about 1, 2, and 3, slightly less than 3, right? So you 300 by 3, you get around 100. So this heart rate is around 100 or maybe more. So is this a sinus rhythm or not? Do you see a P wave? Okay,
There is a P wave.
Yeah, this is a P wave, QRS, followed by a T. So this is a sinus beat. This is a sinus rhythm. This heart rate is fast, right? So it's called sinus rhythm. Okay, understand this part?
Doctor, can you repeat?
Okay. All right. So whenever, because I try to introduce one term by one term, because otherwise you'll be overwhelmed. Okay. So whenever you see the ECG, the first thing you want to comment is the heart rate first. So is the heart rate fast? Is the heart rate slow, or is it normal? So if the heart rate is slow, anything less than 60, it's called bradycardia. If the heart rate is fast, it's more than 100, it's called tachycardia. All right. So how do we know it's a sinus beat or not? The next thing for the rhythm. So for sinus rhythm is the normal rhythm that we have in our heart. So how do you know it's sinus rhythm or not? It must be a P wave followed by QRS followed by T wave. That is one sinus beat. So you see this pattern, this is sinus rhythm. Then you count the heart rate, this is around 100. So this is sinus tachycardia. Understand?
Yes, doctor.
Yeah, so this is the first simple interpretation for the rhythm only. Okay, we're talking about the rhythm only. We'll go on to each segment in the later slide. Okay. Okay, there are a few normal number that I want you to remember. Of course, the most important will be the heart rate, 60 to 100. That's the simplest thing to remember. Okay, I think this one a bit complex for you. Let's see this one. Okay, so the next few slides is actually a slide that you need to remember for exam because it's simplified for you to understand the rhythm. So again, look at again the rhythm P, Q, R, S followed by a T wave. The heart rate is fast. This is sinus tachycardia. Always look for a P wave. When you see P wave, this is P. I cannot have pointer. How do I make my pointer out? Slideshow tools. Pointer. Okay. Okay, how do I change my pointer? This one. Okay. Cannot read. Okay, fine. Okay, so this is sinus tachycardia. So there are times that you do not see P wave, right? So what about this? What about this rhythm streak? What do you see? So the first thing we comment is the heart rate, right? So how do we know the rate? When you look at this RI interval, this is 2, 4, 6. This is about 7 boxes. But this one is about 3 boxes. And this is about 3 boxes and then 4 boxes. So is it regular or irregular?
Irregular.
Yeah. Do you see P wave or not before each of the QRS complexes? So let's see. This looks like a P, but then subsequently you don't see. You don't see two. If you say this is a P, this is a P. One of the bit does not have P, so you don't see a very prominent P wave before each of the QRS complexes. Okay, and the rhythm is irregularly irregular. So if you see something like this, this is called atrial fibrillation. Okay, or in short form we call it AF. Okay, understand? So when you see irregular rhythm without P wave, this is atrial fibrillation. Okay, so understand about this rhythm or not? You just have to remember the pattern. There's a few rhythm that you need to remember how their pattern is gonna be because they will present this way. AF is something very common that you see, especially in elderly or someone in the ward when they are sick, when they are in sepsis, their electrolytes abnormal, some of the hormones abnormal, they will make their heart beats abnormal. So atrial fibrillation is something very common that we see in patients that is sick in the ward. Okay, again, in atrial fibrillation, your QRS complex the QRS is always irregular, and you don't see P wave. Okay, understand?
Understand.
Okay, what about next rhythm? What about this one? It's more challenging, right? Okay, so this is something what we call atrial flutter. Okay, classic pattern what we call it a sawtooth pattern. This look like a sawtooth, right? See the teeth. So that is what we call sawtooth pattern. That is a classic atrial flutter. All right. So what is this actually? You can see this one. This complexes is what we call QRS, right? So all these small bump, this is a P wave. Oh, this is a P wave, this P wave, this P wave, and then this is a QRS complexes. Okay. When you see pattern like this is a atrial flutter. Okay. Okay, let's go to the next pattern. Then you just have to remember how the pattern gonna be, because this thing you just have to remember the pattern. That's what we need to do when we are interpreting the cardiac rhythm. Okay, how about this one? We talk about this one. This is a P, this is QRS, this is T. Then you calculate the heart rate. This is 1, 2, 3, 4, 5. This is 6 boxes. So you get heart rate around 50. Your sinus rhythm, this is sinus bradycardia. Okay, I think everyone should get this right. Okay, then how about this one? Okay, so when we interpreting each of the QRS interval, there's a normal value. So for QRS complex and for PI interval. So I mentioned you before, P wave from your atrial contraction. So when interpreting ECG, some of the block is something what we call heart block. Means the block at the block of conduction from the atrium to the ventricle, from the SA node to the AV node. So the PI interval normally is about 1 big boxes. So where is PI interval? This is P, this is R. Okay, let's go back to the normal one. So you need to not interpret the normal and then you see back. So what about the normal one? This is a PR interval. So at most you get around 1 big boxes. So this is considered okay. This is considered normal. How about this one? PI interval is more than 1 big boxes. Each of the beat also is prolonged. So this is first degree heart block. Okay. How about this one? So if we look at this, this is PR interval. This one looks like 1, 2, 3, 4, 5. This looks normal, right? So this is a PQRS and T. How about this one? Is it long or not?
Long.
Yeah. How about this one?
Long.
Yeah, it's longer, right? If you look at it, it's getting longer, it's getting longer, it's getting longer. And then this one, there is a drop beat. So this is what we call second degree heart block, but this is type 1. Okay. So things that I'm talking about here is something more complicated. But I just need you to go through one round to get a basic overview of how do we interpret a ECG. In the exam, I won't give you so difficult one, because so this is something what we call morbid type 1. When you see the PR interval is prolonged, but the pattern is getting longer and longer. At one point, the PR interval, the P wave is here, it's just not conducted anymore. So the P followed by QRS complexes. That's how a normal conduction be, right? From SA node, it conduct itself to the sinoatrial node, to the SA node, conduct to the ventricle, and then followed by a contraction. When it happened to have a second degree AV block, The PI interval means the conduction started to become slower and slower, and at one point it doesn't conduct. So this is called second degree AV block type 1. Then you have another pattern called second degree Morbius type 2, means type 2 second degree block, whereby the PI interval prolonged is constant one. So if you look at this one, the PI interval is constantly prolonged, and suddenly you just have a drop beat. So this is called second degree heart block. Then you have a third degree heart block. When you have a third degree heart block, means that atrial and ventricle, they are not connected itself anymore. The atrium signal does not relay to the ventricle. So, but the ventricle does not get signal from the SA node anymore, right? So what do? If they don't have signal, the heart is they're gonna stop. So what they do is they have their own signal fire back, their own heart backup generator will fire signal itself from the ventricular node. So here is the pattern that you see, that the atrium and ventricle, they are contracting, or they are firing at their own paces. They are not related to each other anymore. You look at the PI interval, you don't see any relationship. There's a dissociation between the atrial contraction and the ventricular conduction. So let me see. I cannot draw. I'm getting the marker. Tools. I cannot use. Okay. Anyone confused regarding this or not?
Okay, doctor. It's just there's no connection, and then there's like in the ECG, we can't really see the what you call the wave lah.
Yeah. So don't worry about this. I know sometimes it's very confusing. Exam will come out easier one. Okay. So the next few pictures is something that you need to remember more lah. That one is more important. So when you see this thing, this is something more funny, more bizarre, right? Okay. So just remember the pattern. If you see something broad like that, this is a QRS complex, isn't it? It's just that it's very broad. How about the heart rate? If you see something bizarre, don't be scared. It's just interpret like normal. So these are QRS complexes. Okay, it's quite fast. It's quite regular. So what about the heart rate? So there's two boxes, right? So heart rate about 150.
150 tachycardia.
Yeah. So very tachycardia. And do you see P wave or not? Can't really see P wave, right? So when you see something very broad QRS, these are broad QRS complexes. When you see broad QRS tachycardia, heart rate very fast, this is called ventricular tachycardia. So it's called VT. Okay, this is an emergency. When you see VT, it's an emergency that you need to resuscitate the patient with a cardioversion. So this is a VT. Okay, so there are two variants of VT. One is called monomorphic VT, where you see the heart rate is always very regular one. You see the pattern, the regular size is all about the same. The heart rate is always about the same. You see always two big boxes. But you see something regular like that, this is called monomorphic VT. There's another pattern when you see it's always broad complex as well, but heart rate and the morphology of it is not the same. Okay, this is what we call polymorphic VT. The rhythm is sometimes not so consistent, it's irregular, and you don't see P wave. Okay, it's called polymorphic VT. Okay, about this one. And this is another thing that you do not want to see when you are practicing recently is something that very bizarre to see. It's called ventricular fibrillation. So you can see QRS complexes, but then it's very bizarre in shape and very bizarre in size and interval. So this is an emergency where you need to defib the patient. So when you see something very irregular, very bizarre, different size and shape, and very fast, you see the RR interval is very short. Remember the pattern, you see something like that. This is called VF, ventricular fibrillation. So when you see a rhythm like that, you need to start chest compression, and if you have AED, you need to cardiovert the patient. Okay, this is the few rhythm that you need to remember: the VT, VF, AF, and this one. So what is this? You see a small rhythm, and then subsequent is a flat line. So when you see flat line, this is absence of ventricular activity, this is cardiac arrest, this is asystole. Okay. Okay. So the rhythm, there's no way that for you to understand. You just need to remember the pattern of it. What is VF? It's a very bizarre polymorph. All the graph are bizarre, different size, different shape. This is called VF. When they are regular, they're not that bizarre. They are broad complex QRS. This is called ventricular tachycardia. Okay. When you see something like a prolonged PR, it's called heart block. When you see QRS complexes that narrow, irregular, no P wave, it's called atrial fibrillation. Okay, when you see sinus rhythm, it is fast, it's called sinus tachycardia. There's a few terms that you just need to remember by memorizing the pattern. Okay, that is for the rhythm. Okay, and then there's a few segments that just now I want you to remember that when interpreting the ECG. One is the PR interval. If you are good, you can remember that for the heart block. Number two, the things that you need to know is the ST segments. So for normal sinus rhythm, your ST, like I mentioned before, it should be similar as your isoelectric baseline. Okay, so when there's the things that are abnormal about the ST segment is ACS, myocardial infarction or heart attack. So I think this one we talked about in the last lecture. When you see ST up, it's called ST elevation. When you in ACS, you will see ST depression, and this is the serial changes that we'll see with time with ACS. So in acute ST elevation, the ST segment will go up, followed by development of Q wave, and subsequently the Q wave will deepen, followed by a ST T inversion. So the segments that I need you to remember is this one, ST elevation. This is the pattern that you need to remember, and the Q wave. Okay, so see that you guys, let's see you guys can remember this ECG pattern a lot. Anyone want to try how to interpret this ECG?
For the first one, the most top one, I don't see P wave. So I think it's ventricular. No,
So,
no.
no, don't worry. When you see, because when you see there are too many rhythm, right? You don't know which one to see. So there are so many numbers of leads, right? This lead, each lead is looking at different thing. So usually the leads that we use to interpret rhythm is the longest one that we have. Usually we use lead 2. So because lead 2 is the best lead for us to look at what rhythm is that. Then we go in one of the rhythm and magnify from there. So what leads? So there's a bump followed by a spike followed by another bump. So what this bump, what we do call it?
Sinus rhythmia.
So it's a P,
Arrhythmia.
QRS, and there is a T wave. So this is sinus rhythm. How about the heart rate? So let's just make one of the rhythm. This 1, 2, 3, 4. So about 4 boxes. 300 divided by 4, you get around 75. So this is sinus rhythm or not?
Yes.
Yeah, so this is sinus rhythm. And then we go to each of the segment to interpret. All right. So we start with P wave and PR interval. So but that's not our main interest lah, but we can have it. So we have a nice P wave here. The PR interval is less than 1 big boxes, so it's quite normal. Your QRS complex is less than 3 small boxes, which is quite good. And then main focus is ST segment. So is the ST segment normal or not? This is the thing that we want to see in each one of the numbered leads. Okay, so let's start with number 1. So the ST segment, is it normal or not normal? Not very clear, but quite similar if you draw one line here, right? So how about this one? If you draw one line, so what happened? You think it's the same line or is it going lower? This is the ST segment that we are interested about. Okay. So how about this one?
It's going lower.
Yeah, so this is lower, right? So let's look at other leads. So this one not very clear, fine. But let's go this one. Let's say this is isoelectric line. So what happened to here? This is your ST
Elevation.
Yeah, so you can see there's ST up, right? So this is very obvious, it's get pulled by something. So this is the ST segment. So the ST elevation is happening at V2, V3. How about this one? High, right? So V4, V5, V6 we don't really see. So you can see there's a ST elevation in V2 to V5. So what is this? So this is myocardial infarction. No? This is STEMI, ST elevation, myocardial infarction. Okay. How about this one? Okay. So no mind, I think this one is a bit difficult for you. Maybe this one. What do you see on this one? Okay, so let's start with the rate first. Rate and rhythm first. So how about the rate? So in normal heart rate, every beat is supposed to be same one. Like 2 boxes or 3 boxes, they're supposed to be constant because our generator, our battery is firing at the same rate. So is it firing at the same rate or not?
Yes.
So how do we know it's firing at the same rate? RR interval or QR the spike of your QRS complexes. Is it regular or is it not regular?
Regular.
Let's see again. Okay, so let's look at the lead number 2, right? This one is so this one a bit messy. Can I here? Okay, so this one is R. This one is another R, right? So it's this one spike and another spike. So how many boxes is here?
2.
Or maybe this one easier to see now. Because this one they overlap together. Okay, so let's see this one. This one to this one is 2.5, right? So, but this one to this one is about 2 boxes. This one to this one is about 3 boxes. So this one to this one is about 4 boxes. So is it regular or not regular?
No.
Not regular, right? So it's irregular. Do you see P wave or not?
No.
Yeah, when you don't see P wave, it's irregular. Irregular, what is this?
AF.
Yeah, this is atrial fibrillation. Very good. So you just have to remember the pattern. There's only few rhythms that there's a limited rhythm for you to memorize in your brain. So one of the common one is your sinus rhythm, sinus tachycardia, sinus brady, and one of the most important one is your atrial fibrillation. Okay, it's very important. So irregular, no P wave. This is atrial fibrillation. Okay, that is for rate and rhythm. So let's go to each of the segment. So you don't have P, you cannot really see your PR interval. Then your QR complex is quite narrow, it's less than 3 small boxes. Let's go and see at the ST segment that we are interested in. Oh, now I got one phone call. Hello. Hey, sorry. Where am I just now? Okay. All right. So let's look at the ST segments. So this is the, if you draw one line, this is your isoelectric line. So your ST segment is here. So is the ST segment normal or abnormal?
Abnormal.
So what abnormal here?
It's down.
Yeah. So
Depression.
when up we call elevation, when down we call depression. Okay. So this is ST depression at lead 1. How about lead 2? Is it down or not down? So if
Not
it's not so,
down.
yeah, if you draw one line here, so anything below the line, this is down, right? Yeah, so there's ST depression lead 1, lead 2, lead 3 is about the same. And if you look at here, AVL is down as well. Then AVF is also slightly down. And we look at V1 to V6. 1, 2, 3 is about V1 and V2, you look at it about the same. V3 you started to see depression, right? This one is lower than this line. Okay, V4 to V6 is more prominent. This is supposed to be your isoelectric line. Anything down like this is ST depression. So ST depression, ST segments always associated with cardiac problem. ST elevation is a clear thrombosis, a clear infarction, while ST depression is a marker of ischemia, means that patient is going towards STEMI or non-STEMI. So these have to correlate with the symptoms of chest pain, of course, with the shortness of breath, etc. So this ECG tells you that patient has AF and patient has ischemic heart changes with the ST depression. So again, what rhythm is this? Answer is that this is atrial fibrillation. If you look at it, this rhythm, look at the rhythm, look at the P wave. So if you look at this QRS complex, this is 4 boxes, this is 6 boxes, this is 4 boxes. It's irregular. You don't see a pattern in between the rhythm. So this is irregular rhythm, and you don't see a prominent P wave prior to QRS complex. So this is atrial fibrillation. Okay, this is to remember or memorize this rhythm. All right. So how about this one? How to interpret this one? It looks something very bizarre, right? QRS complex is very broad. It looks like a very bizarre pattern, but the bizarre is regular. It's a broad complex tachycardia because the heart rate is 2 boxes, these are 150. So this is broad complex tachycardia. And we see like that. What rhythm is this? This is ventricular tachycardia. All right. You just have to remember this pattern. Same goes with this one. What do you see? Anyone can tell me this rhythm, or whoever can tell me this is good. You can graduate already. Okay, let's start with this one. Mark, what do you see on this one? Only Mark is answering me.
There's no P wave.
Uh-huh.
There's no. I'm gonna guess this is the flutter one, like
Okay.
the what tooth? Sawtooth. Yeah.
Okay, so for those for the atrial flutter, because it's atrium in origin, so their atrial conduction, all the QRS complexes you see, they should be narrow one. So when you see something bizarre like that, you need to know this heart rate is very fast or not fast. So this is fast or not?
It's fast.
It's fast, right? So is this a broad complex?
No,
Is it broad or not broad?
not broad.
It is broad. So if you look at this one, so this is what we call narrow complex. When the QRS complexes is less than 3 small boxes on QRS, when it's less than 3 small boxes, this is called narrow complex. This is a normal one. When you go back to this one, you see your QRS. Let's say this QRS. This is more than 1 big boxes, right?
Yeah.
Understand what I'm talking about? So the one of this complex is called broad because it's more than the QRS is more than 3 small boxes. So if you look at this again, this is QRS. This is your QRS complexes, which is normal size because it's less than 3 small boxes. So this is narrow complex. When you see something like this, let's say this is QRS. From here to here is 1 bit, right? So you see this is at least 4 to 5 small boxes. So this is broad. This is a broad complex. When the heart rate is fast, it's called broad complex tachycardia. Everyone get this point or not?
Yes.
It's between R to R, right, doctor?
Yeah, correct. It's between R to R. Okay. So if you look at this ECG from the beginning, just now we're talking about broad complex tachycardia. What do I say? Whether this is a regular or not regular one. Is the pattern or the QRS complex small or is not? Is it the pattern? Is it all the size is regular or not? We look at this initially.
Not regular.
So compared to this one, this is bizarre, right? This is very different, right? How about this one? If you look at this one, this segment is very bizarre, right? How about this segment? Is it regular or not if you compare like that?
It's regular.
Yeah. So when it is something regular like this, what we call it? This is ventricular tachycardia. Okay. If it's something bizarre, how bizarre? This is something bizarre, right? So when they're bizarre like that, it's called fibrillation. When they are regular, but they are broad complex, it's called ventricular tachycardia. Okay, so just remember this pattern. When it's bizarre but broad complex, it's called ventricular fibrillation. Understand? So what happened to this one? So what can explain this one? So this one is, if you look at the pattern, this is regular or not?
Regular.
Regular.
Yeah, it's regular, right? So your ECG actually printed in a we call it same time one, because the paper started to print from here and then go to here. So print out, this is going out first, followed by this one, like that. So all these segments are at the same time. So the imagine your printer, the whole paper come out, A4 paper come out at the same time. So lead 1, lead 2, and lead 3 actually, they are taken at the same time. And then the next few milliseconds is by this FVR, FVL, and FVF because it's printed out like that. So what is the most likely explanation here? So means that this is happened first, followed by this one. So most likely is patient having ventricular tachycardia here. Patient has a VT here, and subsequently the VT develop into VF. So this is a VT because it's very regular, and then followed by a very bizarre VF. Okay, this is the ECG that you shouldn't be printed anyway, because in the patient like that, most of the time already develop cardiac arrest. So the things that you need to do is start CPR and defib the patient and not the ECG. So this is a ECG that shouldn't be accessed in the first place. All right. Understand? Can you guys understand this? This is a very important ECG, important rhythm that you need to remember because this is a life-saving, life-threatening rhythm that you need to remember. You see this rhythm, start CPR, you find the machine for defibrillation. Okay. So, do you guys have ALS in the subsequent years or this year or BLS?
This is the basic life-saving
This
something.
this ALS lah. This ALS. BLS means the basic life-saving one is only the chest compression and giving the breath one. So in ALS there will be teaching how to interpret the rhythm and what medication to give lah. Okay. So but then the simplest way to understand is when you see this rhythm, you start CPR. Okay. You see this rhythm, you start CPR, and you find the machine for defibrillation. Okay, this is just the pathway for extra for you to understand, but not very important. Okay, so that is for rhythm and the ST segment. So last of it is the T wave. Okay. If you look at normal rhythm, it's my normal. Okay. So our normal rhythm, we talk about P, QRS, ST. We talk about rhythm, and the last segment I want to talk about is the T wave. So T is always following the QRS complex on. Means that when the QRS complex is upright, your T is always upright as well. If the QRS is down going like this, okay, your T is always down as well. That's just how the physiology going to be. Okay, the T wave direction means the bump is always the same direction as the QRS direction bump. Okay, so what can happen to this bump? It can either go very high or it can even invert it. So when it's very high, we call it tall tensor T. When that is inverted, we call it inverted T wave lah. Right. So the T wave is highly related to, one is ischemia, and number two is potassium. So let's look at this rhythm. So you have a P wave, QRS, and then your T is like that. It's inverted one. So it's normal or abnormal?
Abnormal.
Yeah, because I always say your T wave is supposed to be follow direction of QRS. When your QRS is up, your T wave should be up. So this is down. So this is T inversion. When you see T inversion, it could be myocardial ischemia. Another thing you want to rule out is electrolyte problem, especially potassium. When you see hypokalemia, you have T inversion, you have ST depression. Because potassium is very important in the repolarization of your cardiac muscles. So when you have low potassium, you have ST low, ST depression, you have T inversion, and another thing is you have prominent U wave. Okay. Opposite to it, if you have a high potassium, you have hyperkalemia, your T wave, instead of being a very round wave like that, the T wave will become tall, become a tall tensor T wave. So if you see high potassium when you do the ECG, you see something tall like that. If the potassium is even higher from 6 to 8, you get a taller T wave. If the potassium is way too high, you will see like a sinusoidal wave. This is a very rare ECG to see. If you see something like that, patient will go to arrest very soon. All right, remember the pattern. This is something that commonly asked in exam. So let's see this one. Okay, so is this a sinus rhythm or not? Let's look at lead number 2.
This is a sinus rhythm.
Yeah, why do we say that? There's a P wave, there's QRS, there's a T wave. So this is a sinus rhythm. Is the heart rate fast or not? So this is 2.5, this is more than 100, so this is sinus tachycardia, correct? So this is a sinus tachycardia ECG. This is just one of the special ECG that is good to know, that it can happen when you have pulmonary embolism, when you have a blood clot in the pulmonary vessel. You will see a strain pattern in the heart, something what we call S1, Q3, and T3. You see S wave in lead 1, Q in the prominent Q wave in the lead 3, and T inversion in the lead 3 as well. S1, Q3, T3. It's just a phenomenon that we commonly will see in a severe pulmonary embolism. Something just good to know. Okay, that's all. So I know today lecture is a bit complex for you to understand, but the most important few slides is still this one. Okay, most important one is to understand the rhythm. Know about sinus tachycardia. Atrial fibrillation is something very important to know. Day to day, you see this one. Atrial flutter. What is bradycardia? And most important one will be your VT and VF rhythm. So these two you cannot miss. You cannot forget them. Okay. And of course, the few more smaller print segment that you need to know is ST elevation, ST depression, and relevant to the T wave, the hypokalemia and hyperkalemia. Okay. Anyone has any question? Anyone has anything confused, don't understand?
Doctor, if you were to ask this question in Minitus, right, will it be MCQ or SAQ?
Oh, this one okay. So like I said, I cannot tell you what's going to coming out. I can tell you what happened in the past. Okay, so what happened in the past is we put up a ECG like this. Then you have to comment on this ECG. What are the findings of on this ECG? So which I already tell you the answer, right? So in the past, the question would be like this. So the patient comes in with the chest pain and shortness of breath, and then what investigation you want to order. So something like that. Then you answer your investigation, and then here's the investigation order. This is the ECG of this patient. What positive findings that you see, or what diagnosis that you see from this ECG? Then you answer from that. So usually it's from the it's kind of like short essay or short answer format. Okay, any other question?
No question.
Then, doctor, just now in the beginning, right? The answer is flutter lah, right? Like the first.
Give another chance. Okay.
Or is it? There's no P wave. No P wave.
So you can understand what is flutter. So let me go back to this one. So just remember, okay, so what is flutter? What is atrial fibrillation anyway in the physiology? So if you look at it, why our SA node is here? See, and typically it was designed very genius in a brilliant way, because you see the SA node is at the apex, it's at the highest part, just near your jugular vein here. So your battery is here. It kicks off a signal, and then it transmits the signal through the pathway and to the AV node near the ventricle. And this signal actually stimulates the heart to contract. So that's what a normal sinus rhythm be. So when you look at the atrial flutter, what happens is that different part of this wall, they also start to fire. They also want to send in their electric signal as well. So they keep on fire like that. So that's how it stimulates the atrial contraction. You want to give you a bit of contraction, but then every part of the atrium now is firing. Part of this one muscle is firing. That's why I give you the small tooth, the saw tooth appearances. But your AV node is only here. You see, it's like your highway is going through the toe here. All the cars are coming in. All the firing is coming in at the gateway here. And it can only give so much of signal, because one is fired, one is once one signal has passed through causing a contraction, you'll be in a refractory mode. Means that the AV node need to rest. You need to rest for a few milliseconds before another signal comes in. So it can only allow one signal pass through at one time before it rests and recharge again at the AV node. So what happened in atrial flutter is that everywhere in the wall try to fire in a regular way. They try to fire, ask the atrial to contract and pass the signal to AV node, but they cannot pass through. So that's what you see this pattern, like here. Where's my small through?
Basically, it's like it's on off on off on off. Then that's why it's like that lah.
Yeah. So basically, what it's telling you in the physiology is that the signal in the atrium are firing. Different foci is becoming a pacemaker. They want to fire as well. So they're sending the signal. They want to fire. That's why the ECG able to pick up. All these are small ectopic beats that firing from the atrial wall. So they give you this bizarre pattern, but none of it conducted until as one beat. You see, this is P, but it doesn't follow by QRS. That means it's not conducted to the AV node because your AV node is in a resting mode. So one of the beat get through, become a QRS, but then you need to rest. That's why another beat that comes earlier, it cannot conduct. That gives you this pattern that sawtooth appearances, because they fire regularly in the atrium, but then doesn't conduct it. So if you look at it, when it conducted, it's actually conducted through the AV node. That's why your QRS complexes is actually narrow. Okay, so for atrial flutter, you will see a lot of P wave, but QRS complex is narrow, and not all of them are conducted. So you see something like a sawtooth appearances. So the thing that is fast here that has extra here is the atrial beat, the P wave beat. Whereas in the beginning, this photo, what do you see? Do you see a P wave?
No P wave.
Yeah.
But then
broad, right?
Yeah, it's broad complex.
Yeah. So what is this?
This is ventricular tachycardia.
Yeah. So this is VT. Okay. So it's a huge difference between VT and your atrial flutter. Okay.
All right, doctor. I think that's all.
So don't worry, the ECG you come to revisit ECG again and again for the next few months. Okay. So we'll keep on revising all these small print again. So again, the most important slide is the rhythm interpretation slide and how do you calculate the heart rate. So the small print you can go through once, and then the most important one is still knowing where is the segments, knowing how to count the heart rate, knowing each of the rhythm, the common rhythm that I taught a few times, and also knowing the ST segment and also the and the T wave. Okay, those are things that will keep on coming out in exam. Huh? Okay.
Okay, doctor. We take picture of attendance. Amanda, can you take picture?
Oh, okay.
Sorry.